This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I want to start out by drawing your attention to our website, where you can check out anything that's show related when you go to professorbram.com. That's professorbram.com. At the website, you can find the latest show, see my talks in the media, order the latest book, and also look at how to participate in research. This is all stuff that can help you grow in the world of EMS research. Like right now, I have a research study open for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com and click on the current research tab to apply. Today, our guest is Dr. Casey Patrick, who's the medical director for the Montgomery County Hospital District EMS service in Greater Houston. This is where he helps develop and produce the MCHD Paramedic podcast. And, Dr. Patrick is a board certified emergency medicine and EMS medicine physician. I just want to say, hey, welcome to the show. Tell us more about yourself for the audience.
Thanks for having me, Bram. It's an honor and a pleasure to be on with you today, talk about our service and some of the work we've done. I am an emergency physician. I live up in Montgomery County in Conroe. I practice there both in the emergency department and work with MCHD. I've been here in the area for about 15 years, and I started at MCHD in 2016. There's nothing better than working with the medics, EMTs, AMTs here in the county. People often ask what a medical director is and what they do, and my primary focuses and really loves are education, providing oversight, helping to provide a framework, keep the patients of the county safe.
Well, it's really fun for me that I'm also in the Houston area, and, you got my attention not because, we're in the area in the same field, because we actually haven't met face to face, but you did put out this April 2024 research project, and it was published in the Pre-Hospital Disaster Medicine and called Pre-Hospital Surgical Cricothyrotomy in a Ground-Based 911 EMS System, a retrospective review. And wow, this is not something that we commonly see. I just breezed through that title, and I just want to read it a second time just so that everyone can hear and process it. The article title was Pre-Hospital Surgical Cricothyrotomy in a Ground-Based 911 EMS System, a retrospective review. And really, your study describes how managing the airway is crucial in emergency care, especially when the patient's critical. And the surgical cricothyrotomy is a quick and effective procedure used, especially when less invasive methods are just not successful. So your study looked at when and how successfully the surgical crics are performed by paramedics in a large suburban EMS system. And the methods just involve the fact that you reviewed between the years 2012 and 2022, reviewed the fact that there were 31 patients, and those were the ones who had received this procedure. The research examined various factors and things like if the patient had a heart attack or if this was a trauma or medical issue. But in general, things like how many attempts to manage the airway before the procedure and how long it took to perform the procedure. These were the things that you were managing or, looking at. And so the results showed that 42% of the procedures occurring due to trauma and 58 were due to medical issues. On average, the procedure took 17 minutes. It was faster for trauma patients compared to medical patients, so in 12 minutes versus 19 minutes. The procedure was successful in 94% of the cases, and before the surgical procedure, 55% of the patients had attempts to manage the airway with a tube. 29% of the cases, more than one attempt was made. When multiple attempts were made, the procedure took longer compared to cases that had no prior attempts. I think that this makes sense for an experienced clinician that, gosh, when you have these cases, we try if they're, if it's a more difficult case, it's going to take longer. So these are all things that came out and struck true just in the sense making part of this. And, you just were really showing that paramedics can successfully perform surgical crics in the pre-hospital setting. And I think that it's important to decide, quickly, right, if the procedure is needed, because we're in a spot where, gosh, can this patient breathe adequately? Yes or no? And it can be a scary, intimidating time with a procedure that we don't do that often. I've been a paramedic 25 years and I've done not that. So, let me just ask you, what inspired you to investigate the use and the success of this particular topic, looking at surgical crics?
Well, that's, great overview of the gist. And there's a lot of points in those numbers that you just read. We will get to those. Realistically, for the listeners that aren't aware, Montgomery County Hospital District EMS serves the county due north of Houston, about 750,000 people, 1,100 square miles. We have upwards of 35 trucks on the street at any given time and do all the 911 transports here in the county. And the inspiration behind the paper really stems from good oversight of what is truly a high risk, low frequency procedure. And so this didn't stem really as a research project to start. It started as, where are we with our surgical airway competency? Where are we with our training? How good are we at doing this? And then that sort of snowballed into, well, who do we do this on? How long does it take? And then that next step was, what does that look like in aggregate? And we were very lucky to partner with another EMS physician who was working in Houston at the time. He's now up with Dallas Fire, Dr. Al Lula, who took the role as a primary author. But really it started as, this is high risk, this is low frequency. How good are we at this at MCHD EMS? Do we have room to learn, to grow, to improve, basically from an education standpoint, from a protocol standpoint? And then what can we provide to the EMS world, region, nation as a whole, from what we've gathered here? Because like you said, this was 10 years of data and we had 31 in our county. So we averaged 3 a year, which, looking at the rates of surgical airway placement, both in the ED and the EMS system, that's a pretty middle of the road estimate that you would think for the number of runs that we have. We currently are probably getting close to 90,000 calls for service, upwards of 70,000 runs. We have about 300 plus paramedics and a handful of AMTs and EMTs here in the service. And we manage a lot of airways every year. And thankfully, only a small percentage of those do end up with a surgical airway. Some of those are medical, some of those are trauma. But yeah, the times were really some of the pieces that, when you get into the details, that were really impactful to me, because those times aren't really, and just to clarify for the listeners, when you talk about 12 minutes, 19 minutes, even some of the longer times that were out there in some of these cases, that's not really time to complete the procedure. That's time to manage the patient, make the decision to do a surgical airway, and then to complete the procedure. So that's time from patient contact to surgical airway completion. We didn't have.
Thanks for clarifying that. That's a big deal difference. Okay.
Yeah,
wow.
we didn't have a time clock. This was all chart review. This was retrospective. So there's limited, limitations that exist there. But we didn't have a clock on when they started a laryngeal handshake, to vertical incision, to horizontal incision, to boozy insertion, finger insertion, right. Those sort of things. That was just time from patient contact to end tidal, waveform capnography, evidence of placement after the surgical airway was started. So,
I read the article and I guess I just didn't pay attention to that. So It makes so much sense now that, and also that, the trauma patients would be getting that airway in faster. So I want to know, do you worry about EMS providers who are overconfident and undertrained? Like, isn't that a big worry?
I mean, yes, for sure, especially in Texas, we're a delegated practice state. So we're 100% the medics that are out there on the street are delegated to practice under my license, or Dr. Dixon's license at the time, who recently retired. Our past medical director worked very closely with Dr. Dixon to shepherd this quality project into a research paper. I would be remiss without thanking him. We got a couple other folks we'll thank as we go along. But yeah, I mean, this is not a procedure that, and we did hit on this in the discussion, paramedics can successfully perform surgical airway placement in the field. And one of the caveats that was a little different about our work than some of the existing work is that there wasn't online medical direction. This was not a procedure that the medics had to call myself or Dr. Dixon to get online approval when they were in the field. They didn't even have to call a chief level or supervisor level provider. This was one, and when it's an emergent situation and we've lost the ability to oxygenate, we can't ventilate, airway patency's gone, surgical airway is emergent, capital E emergent. So yes, we did this without online medical direction. Yes, these were ground-based 911 providers. These weren't like in the European system. There was no physician-led teams on scene like you would see potentially in Germany or in France. These were ground-based 911 medics making this decision based on patient acuity there in the moment. So that made this group, these 31, a little unique. But the caveat, and what we're lucky to have here in Montgomery County, and what I'm thankful for as the medical director, is that we have a culture of education. We have a culture of training, and that's not something that we take lightly. Part of that, admittedly, I understand, requires a budget, and we are lucky that we're supported by, the MCHD board and the citizens of the county to provide top level pre-hospital 911 critical care in the field here. That's not available to everyone out there. That doesn't necessarily make it right or wrong, but it's not an endeavor that you can write a protocol, send an email blast out, and now everybody can do surgical cric. It takes training, retraining, continued training, scenario-based, dry run, models. We are lucky to have cadaver training here in the county yearly that our medics have access to. So yes, they can do it, but it has to come with significant oversight, significant training, education, and then that has to be continuing and ongoing.
Because so it doesn't happen the same way.
No, and so can do it. And yes, we've got a model and a roadmap that we're comfortable with, but I am very well aware that just because someone else out there that has a smaller budget, a smaller service, lack of access to some of these training modalities, they may say, you know what, this is too complex. This is too high risk for us to oversee, to manage, to feel like it's safe. We may not have this in our protocols. But honestly, there are some, well, it's rare when you think about angioedema, massive facial fractures, anaphylaxis, severe burns. While they're not common, there are airway cases that will present themselves to us. No matter how big or small of an area you are, over time, you are going to contact a patient that has plan A airway. Normally that's, today, most commonly video laryngoscopy. Plan B, supraglottic airway of some sort. Plan C, back up into the bag. Plan D, surgical airway. But you'll run into a patient that won't follow that normal pathway, that will need a surgical airway straight away, that you'll look at and they're on a lisinopril or a ramipril or one of the ACE inhibitors, and their tongue and their lips will be so swollen that plan A has to be surgical. And so I would argue, even in those services that are more budgetarily limited, there are still some lo-fi ways to get really good surgical airway training. It doesn't require quarterly cadaver labs to be good at this. There are some very inexpensive 3D cric and trach models that exist out there. There's a lot of really excellent online education and YouTube videos and other things that we've used and copied and borrowed from. And realistically, dry runs and continued discussing this with your partner. When are we going to make the decision to do this? What patient types do they look like? And then, if I'm the primary person performing the procedure, where does my body go? Where does my hands go? You're my partner. What do I need you to hand me, and in what order? And we really simplify the procedure here at MCHD. We use a scalpel finger bougie technique that really only requires an 11 blade, a 6.0 tube, a bougie, and a 10 cc syringe, nothing more. So we don't complicate things with percutaneous kits or even tracheal hooks or some of the other things that can, I believe, overcomplicate what should be a very quick and straightforward procedure to do. The hard part is in the decision to make the move towards performing it. That's where that 12 minutes, 19 minutes, that's where those times come into play. And that's where we have to think of as educators and medical directors, could that 12 and 19 minutes be 5 and 9 or 4 and 8? And is there room to get to that surgical airway decision quicker? Would that improve outcomes? I don't have the answer to those questions, but that's where future research and future education, I believe, should go.
So I think the standard around the country is that a lot of paramedics get the ITLS, trauma class. And I think that happens like every 3 years. And so it's in the protocol to, to do the procedure. And the most paramedics, just pray that they would never be in that kind of position. And I think about my best friend is a Army medic. And, I think about the kinds of training that they get and how intense their training is. And it's funny because if you talk to almost any military medic, they are ready to pick up a scalpel and stab you. They are ready. They know how to do it. And they're ready. It's so funny. And it scares me because I'm like, oh, this is a procedure that I am very standoffish with, and you're ready to come at me, And so I want to imagine the worst case scenario where, we might have to perform a surgical crack in the field. And that kind of worst case scenario is probably a situation where there's only one paramedic on scene and we have a combative trauma patient, can't intubate. I just wonder, do studies like this give false hope that a paramedic is going to get a successful airway, if they get out that knife?
The devil's in the details. If you're properly trained, if you're credentialed, if you have scenario-based training regarding situations where surgical airway is going to be necessary, if you have a protocol that allows you to move forward with surgical airway when it's needed, if you've got foundational resuscitation and sedation protocols in place, because realistically, it's not a singular, there's a lot of surrounding pieces. There's not one piece of this puzzle. And so I wish I could give you a simple yes or no answer. My answer is yes, but you have to have the other pieces in place.
So I think we can agree that this is a last ditch effort. It's just, some people may have more tools in their toolkit to help them before they have to pull the trigger on this last ditch effort, right?
Yeah. And if somebody's a can't oxygenate, can't ventilate patient, you have to think about your options at that point aren't widespread. There's not several other things you can reach in your toolbox and lean back on, because you can't bag
so
them.
What about, because I'm not educated in this area, but let me ask, what about doing the needle crike? Like, why aren't we just immediately going for that and then do the surgical crike, once we get some bit of oxygen saturation from that needle? Like, since it's such in these kinds of cases, and oxygen is the emergency, is that another tool that we should consider, or just give me your thoughts?
Needle crike is sort of classically thought of as a pediatric procedure, or pediatric jet ventilation. Right. Needle crike with a larger bore angiocath in kids. The problem with needle crike in adults is it's not dissimilar from the problem with needle thoracostomy, is that 14 or 16 gauge angiocath just kinks too easily, becomes clotted too easily, fouled with secretions, blood, vomitus, whatever you have in the way. It doesn't allow for suction. There's no room for kinking. And then your volume of air, and just from a physics standpoint, the ability to oxygenate is quite limited, and your ability to ventilate really is nil. So, are there people out there? Are there protocols in place to do needle cracks? There are. But in the end, this is truly, a life or death situation. If we are going to make this call, it has to be because there is no other option. I trained 20 years ago, and there was a procedure that was in vogue at the time, a retrograde intubation, where needle and a guide wire were inserted through the cricothyroid membrane past caudally, cranially, and retrieved, and a tube basically passed over a wire. There's lots of techniques that have existed over time. In the end, with proper training, the procedure itself most times is not terribly difficult. Identifying the thyroid cartilage, the Adam's apple, with your non-dominant hand, really maintaining control of that, and then using your index finger to ski slope, for lack of a better term, down the Adam's apple will get you to the cricothyroid membrane every single time. So really, your non-dominant hand is the key to identifying your anatomy, and then a vertical incision, then followed by the horizontal with the bougie passage. As someone who does a lot more skills training, I've practicing in emergency medicine, again, upwards of 20 years, and I've done a handful of these myself. After working in EMS, I am a little more, I would say, comfortable with the procedure, just because when you teach something, you become more comfortable with it, just as you do when you perform it. So for me, it's not quite as nerve-wracking as it once was, but man, it's a 9 out of 10. Like, there's no way that you're going to be in this situation and not be amped, jacked, nervous to the hilt. That's just the way it's going to be. But I wouldn't be any less nervous using a less invasive technique, because none of those things would be something you're going to do in a common scenario. I'm not going to have any experience with a needle cric if I had, another option. It would be just as nerve-wracking. So if I'm going to have to perform a procedure, I'd rather do one that I can take some mental reps on, some physical reps on every quarter, which is in my own practice how I try to approach this. I try to run through a handful of mental and model reps every quarter, keep it fresh in my mind, the steps that I need to go through, what I need to ask my team for, what patients are going to look like when I make this decision. And then it's a matter of trusting that, and then taking an opportunity to do your, cadaver training whenever you can. Those opportunities are few and far between, but we emergency physicians like to try to suck those up just as much as the medics out there do, because there's no magic. It's going to takes practice and repetition. But I think people underestimate the value of dry reps and mental dry walkthroughs with your partners. My wife is an emergency physician as well, so we sometimes go through mental surgical airway reps when we're in the car. I know that sounds super nerdy, but a dry rep is better than none. And it's something we have to think about. We have to talk through. I would rather learn the biggest bang for your buck, most likely chance for success, high risk, low frequency procedure, be comfortable in that, use that as my go-to, than try to dance around the obvious fix with things that I might convince myself are less invasive, but probably less chance of being successful, more chance of complications. So that's a long-winded way of responding to your needle cric question.
Yeah, well, I want to say that I appreciate the fact that you're highlighting this mental preparation part of it. This is how I have really practiced my, self. I remember back when I was 19 years old and learning ACLS for the first time, I would sit in the back of the ambulance and I would look at the drugs that were in the kit, and I would think about not just the dose or the name of the drug. I would think about opening that box. What color is that box? And how this stuff all has to flow. And, when we're doing a procedure that you haven't done before or haven't much experience in, it's extremely stressful. I know the first time that I delivered a baby, I lied to everybody there. I told them all I'd done this before, and I just, went with it. And of course, I never had to lie again after you lie the first time, but whatever to help someone get confidence. And I have always just been, I think that also I want to share, thank you for suggesting the bougie, because, the bougie insertion, I think makes a big difference for those who haven't thought about that. But I want to ask you to address my biggest fear when it comes to this procedure, and that is blood and my gloves slipping around. Like when you do a urinary catheter, the hand position is super important so that you don't slip around, right? Because you're trying to, get to a hole. Same thing here. You're trying to get to a hole, and you don't have lube that's slipping around, but you have blood, which is probably more slippery. Tell me more about that aspect of it.
You're going to start with a non-bloody surface most of the time. I mean, if there's severe trauma, there may be blood there to begin with. You got to try to get things as dry and clean as you can with gauze. But I'm a right-handed person, so I tend to try to isolate and handshake with my left hand so that I can use the scalpel, the surgical end, with my dominant hand, the right hand. So I try to get the left hand in place without blood, vomit, snot, whatever else is there. And then that's in a good firm spot. And once that handshake is there, I'm not letting it go. I really believe that manipulation, moving, kind of not minding your non-dominant hand is one of the biggest mistakes that I see learners make. And then really your amount of bleeding is going to depend on the perfusion of the patient. In the handful of these that I've done, some of them there's very little blood because the perfusion is so poor to begin with. If we're talking about a cardiac arrest patient, other times there's been much more bleeding, and you really have to operate on feel. But in the end, the procedure itself, when you think about the incision, the probing with your finger, the second incision and bougie passage, it shouldn't take much longer than 20 to 30 seconds. So you're not exploring and dissecting Lute's bowel and cauterizing things. I mean, and you're not looking for aesthetics here. Larger is better. You want to stay midline to stay away from the thyroid arteries. You do not want to get in there. I've not gotten in there, but seeing situations where that has happened, it can really get bloody. There's a lot of blood flow to the thyroid, but you really want to go a little longer, a little larger than you would think. Move quickly, because once you commit to it, you've really got to go. The longer that you make micro movements and sort of nibble at the edges, the more blood and the more complications and the more doubt that's going to be sewn into your brain. So realistically, I try to think of it as you're standing at the cliff, you see the water down there, you know that it's deep enough for you to jump in. You just got to make the leap. And once you do, you've committed to it, then think about it as a not terribly complex procedure. Realistically, the why you get there and the why that you pull out the scalpel and have your bougie ready and have your finger and your anatomy and everything in mind is a much more complex and much more difficult decision. I really believe that, your partner in the procedure, and speaking in EMS terms, speaking in my terms in the hospital, whether or not I've got an emergency physician partner or one of my nurses or a respiratory therapist, really having good communication with, your assistant, for lack of a better term, is totally key, because you don't want wasted movement. You don't want drop tools. You want to make sure that everybody understands, hey, here's what we need. We need a scalpel. We need a bougie. We need a 6.0. We need a 10 cc. We need some gauze potentially if we're going to try to dry things off. We need to have suction ready. We need to have a bag ready. Those two things are always very, very important. But where are those things, and in what order are you going to hand those to me? That's where that dry run back at the station or in the truck when you're posting and killing time is really, really important, because I'm going to want the scalpel to hit in my right hand, because I've got the Adam's apple in my left hand. I don't want to start over again. So I want the scalpel in my left hand. I'm going to make my vertical incision. I'm going to make my horizontal incision. Now I've got my left index finger in my incision. I'm going to reach with my right. I'm going to sit the scalpel down, reach with my right hand again. Now the bougie needs to go into my right hand. I would like the bougie to go in very, very proximal, such that the coude tip is easy for me to access. I don't want the bougie, the long bougie in the middle of my hand, so I've got to adjust it. Those are the little things that can really make or break the procedure. And if you practice those with your partner, then you've got an idea of, what I want as a proceduralist. you may be listening out there and say, hey, I do my cric totally differently. I want my bougie here, or, I want a different blade syringe or a scalpel, excuse me, or I want it in my left hand or not my right hand. I'm not saying my way is the right way, but I think anyone out there should have their way and should have really those micro movements and micro pieces of the progression very dialed in and in your mind, so that when you practice it with your partner, that they know exactly where you want things. And then I'm going to put the bougie in. Now the bougie's in place. That's when you're kind of golden, because you've got a device in the airway. Now I'm going to ask for the tube. I'm going to slide the tube over. We're going to use end tidal to confirm placement, just like we would in any other endotracheal intubation. And so those sort of little pieces of the puzzle of making sure your partner is able to pass and help and connect and disconnect, all those things really is key. And I think it's underestimated.
So I'm laughing to myself because I'm thinking about how it's sort of funny that the aggressive action of taking a knife and attacking the patient is the best advice to give, right? Because we're gonna make up our mind and then we're not backing down. This is gonna be a full on get it done kind of scenario. Let me before we close on the topic, can I just ask about your thoughts, maybe tricks or ideas about sedation with the procedure?
Yeah, that's going to depend the patient. Yes, I believe sedation is necessary in some of these patients. For instance, an angioedema patient that was progressing very rapidly, stridorous, hypoxic, potentially hypoxic thrash. There absolutely very well may need to be a need for sedation in that patient. A patient that's cardiac arrest and comatose and massive vomitus and GI bleed and unable to see, to suction. That was the last surgical cric that I performed in the ER, was a patient that arrested EMS transport, arrested basically right in the doorway of the shock room bay. And there was so much vomit. It was like a mountain of vomit, and 2 large bore suction catheters later, just everywhere. And an iGel is not going to be successful in that situation. There was no way that I could see with a video laryngoscope.
Right.
And I made no progress with probably 10 to 15 seconds of large bore suction. And so I just moved quickly to a surgical airway because there was no other. What are your other options? And at that point, the patient had just lost vital signs. We needed to get to compressions. We needed to get to potential defibrillations, all those things that are, we know, totally vital for a medical cardiac arrest situation. But, to control the airway and to really secure it and, protect from further, there was going to be some aspiration. That patient I did not sedate. I just moved to a surgical airway and proceeded with normal ACLS progression.
What about a patient who may be near arrest, that you cannot ventilate, that you have copious amounts of vomit? Like I had a patient one time who arrested that had so much spaghetti coming out of their airway that it was undescribable. So the point was that I could not intubate them, and the aggressive actions that I took to clear the airway were unlike any other I've had in my career. But the end of the day, it was a BLS airway that got to the hospital. And I think about things like, a surgical cric, because I'm like, would I have gotten myself into a worse mess? I don't know. I don't know if it doesn't matter, because they don't have an airway, right? It doesn't matter what you do. If they can't breathe, they can't breathe. So,
and in that situation, if you're moving into a cardiac arrest paradigm, and we're talking about, what really matters, hands on chest, minimize pauses, compression depth, compression fraction. In most situations, the airway is a necessary piece to the puzzle, but it's a small piece relative to, we have to replace perfusion with hands on chest. And oxygenation and ventilation are important, and we have to have that piece. But most times in our service, we are primarily a iGel, supraglottic airway believers and practicers when it comes to our out-of-hospital cardiac arrest situations. But if we don't have end tidal and we're not ventilating, if we don't have chest rise, if we don't have bag compliance, that has to be addressed. We know that compressions and early defibrillations and minimizing pauses are the keystones, but we also have to have end tidal. And if you can get end tidal via a supraglottic airway, you can get end tidal via an endotracheal tube. If you can get end tidal via your bag valve mask and you see some chest rise and fall, then all of those are not a can't oxygenate, can't ventilate situation. So your evidence needs to be multifactorial. It needs to be chest rise and fall. It needs to be compliance. It needs to be waveform capnography, in my opinion. So if you have those things, even if it's not ideal, you're really not in a can't oxygenate, can't ventilate scenario. Now, if you think about a copious spaghetti, we're going to do things like large bore suction. You may use your McGill's and just start to scoop. I've done that before. And you may not get to ideal, but you may get to some, okay, at least I'm oxygenating some and I'm ventilating some, and I can move ahead with, safe transport and continued resuscitation. Really, the surgical airway would come in when there's no chance for ventilation and oxygenation. And that would be, you had a foreign body that was so obstructive that you couldn't move it, you couldn't bag through it, you couldn't intubate through it. McGill's failed. And when you bagged, and you've bagged folks before that, or at least I have, I'm sure you have, where tubes are misplaced or you have the mucus plug and you're just squeezing against nothing. Those are the times where I believe the surgical airway is the answer. Most times, thankfully, we can clear, we can use our core airway techniques, and we can get to some at least reasonable spot of oxygenation ventilation. But if you couldn't clear it, and like in my patient, I was making no headway with 2 large bore suctions cranked up to the max. And so, whether you're using it like you're in the truck and you're using the truck suction and the portable suction that's in your bag, that's the setup we have at MCHD. In the ED, I just had 2 suction canisters on 2 different suction devices, and I crank those all the way up with, not a huge fan of yank hours, no conflicts of interest, but we use the Decanto large bore suction in our service. I like to use those in the ED as well. If those babies aren't going to suction through it, you don't have much other choice. That is you can't ventilate through copious vomitus or, through spaghetti if you can't remove it. It sounds like you were able to shovel and scoop. I mean, I've used the back of a laryngoscope blade to scoop before, not to sound crass, but
I put my hand all the way down the guy's throat. That's how bad I put my hand all.
You can do that.
There was no other thing to do.
Yeah, you can do. I mean, to clear it, I mean, you're in the position where if you can't ventilate, that's a situation we have to think surgical. I would guess.
For sure. Thank you so much for covering this topic with us, because it's not something that we think a lot about. It's like one of those things that we put off in the back of our minds. Hopefully I never have to do it, but we all have to be prepared every day to do the tough job. And I appreciate what you're doing. And I think that our listeners do as well.
Yeah. I got to thank Michael Wells, one of our data analysts here at MCHD, for helping us extract this data from our electronic records way back in 2012. Matthew Gilbert was a resident physician at HCA Kingwood down on the south side of the county that worked on our bibliography, and Kelly Rogers Keene at Baylor helped shepherd us through the IRB process. So that's all the authors on the paper. There's a recent, I just saw on social media yesterday, big review of EMS surgical airways. So I will send that one to you, and you can stick that one in your show notes. We use a YouTube video by some of the folks at the University of New Mexico, some of the EMS folks there, Darren Brody and some others that are true airway experts. So happy to share that link for the listeners as well. It's a really good YouTube cadaver-based instructional on the use of scalpel finger bougie technique. It's very similar to what we use here at MCHD. And I appreciate the chance to come on and talk to your listeners about our surgical airway experience. It's just it's a single service. It's a small number of patients, but I do believe if the conditions are right and you set your pieces in place properly, that ground-based paramedics without physician-led teams, without online medical direction, can successfully do this. Shameless
right.
plug, MCHD Paramedic Podcast. Check us out monthly, wherever you listen.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplow from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for you to review on our website at iphmi.com, and also published through GEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.